Okay, well, it's just shortly after midday. I can see our participant number has hit 50, so we'll get started for this really exciting webinar. I'm glad you're able to join us. My name's Dr. Paul Wheatley-Price. I'm a medical oncologist in Ottawa at the University of Ottawa, and I'm the former president of Lung Cancer Canada, and I sit on our research panel as well with the chair of our research panel, who's on the call here, Dr. Zhaolin. So welcome to this meeting where we're going to be celebrating two award winners of grants awarded through our collaboration with the Lung Ambition Alliance, and I'll talk a bit about that again in a moment. Before we begin, this is a virtual meeting. Maybe, Michelle, we could just go to the next slide. Oh, no, not that one. The next one. Don't need to look at me. So you know, we often do land acknowledgements, and because we're here in a virtual meeting, so we could acknowledge wherever we are in Canada or indeed internationally. And what I just would like to stress is that Lung Cancer Canada, you know, our commitment is to supporting lung cancer patients and their family members from coast to coast to coast in all provinces and territories. And we recognize that lung cancer is a disease that disproportionately affects our Indigenous communities, also people in rural communities, people from lower socioeconomic statuses. And you know, our role that we take very seriously is to try and address some of these equity issues that are clearly evident in Canada when it comes to lung cancer. And so, you know, we ask for your ongoing support of us as a charity as we strive to really support all people with lung cancer. Now, if we go to the, no, I think we'll just go there. So just a little reminder about Lung Cancer Canada. So Lung Cancer Canada is our only national charity that's dedicated to the support of lung cancer and patients with lung cancer. We support the lung cancer community. We're involved in promoting early detection, advocating for screening, for example, advancing critical research through a number of research grants that we have now, and we'll come back to that, of course, in a second. Eliminating the stigma associated with lung cancer, and advocating for the change needed to ultimately conquer this really devastating disease that most commonly diagnosed cancer in Canada, and by far, unfortunately, the #1 cause of cancer deaths. So, as I said, we've been more and more being able to support research at Lung Cancer Canada. The first sort of 15 years of our existence was really primarily about education and support. And now we're able to have the capacity to support a number of research grants through various funds that we have. And today we're really acknowledging our collaboration with AstraZeneca and with the Lung Ambition Alliance. So this reflects, you know, our dedication to funding innovative research. Our different grants have different priorities, and these Lung Ambition Awards, we're now in the second year, and Dr. Geng and Dr. Leighl are the two winners, and they're going to present their research to us in a second. This is actually, we're now open for applications for the third year of the Lung Ambition Awards. So do check out lungcancercanada.ca, that's the website, and you'll be able, that will guide you to the Lung Ambition applications, which close in February of 2025. So you've still got plenty of time to put in your applications. Now, you didn't dial into this and call into this to listen to me going on and on, so I am going to introduce the first of our award winners, Dr. Fei Geng. He's a PhD scientist at McMaster. As you can see there, he's the program chair in biotechnology. and he teaches molecular biology, biochemistry, immunology, virology, genomics, proteomics at McMaster, and he has been awarded one of the 2 Lung Ambition Awards this year with the presentation on the development of a new blood-based test for early and cost-effective lung cancer screening. So, Faye, congratulations on the award, and I will pass the floor to you.
Thank you so much, Paul. I really appreciate your introduction, and thanks for having me. Just give me one quick second. Let me share my slide. Okay. All right. Thanks, Michelle. All right. Thank you so much, everybody. It's great to meet you guys in this great webinar, and I'm very honored to receive this Lung Ambition Award. And as Paul introduced, I'm an associate professor in McMaster University, and we are in biotechnology program in W School. So we are here to explore the possibility of repurposing a lung cancer screening system to enhance the current system we have in Canada. Sorry, Michelle, I'm not able. Just one second, everybody. I'm not able to control the slide. Okay, excellent, thank you. So, yes, everybody, as everybody know, there's over actually 1.8 million lung cancer deaths worldwide each year, and the overall 5-year survival rate we're looking at over 20%. I think the point is for lung cancer, and actually one of the motivation for my research here at McMaster is that well, if we could achieve early detection, 92% of the people's life can be expanded. So we're looking at 10-year survival rate if we can achieve early detection. So that's why early detection is truly going to make a very positive impact. So as Paul introduced earlier, lung cancer stays as the leading cause of cancer-related cell deaths in Canada in 2024. And the number projects that 32,000 Canadians going to be diagnosed with lung cancer, and account for 13% of all the cancer cases across the board. So it's quite significant. And when we're looking at the landscape of lung cancer screening, if you can tell from the map on the right-hand side, not all the provinces, actually less half the land in Canada has this lung cancer screening system in place. In the BC, Ontario, Quebec, and Alberta are the provinces which has a lung cancer screening protocol. And the current eligibility for lung cancer screening is between 55 years old and 74 years old. And the population are limited to smokers, either currently smoking or have smoked in the past, and have a smoking history of 20 years or even more. So here's the challenges for the current system we have. Thank you. So the challenges for a current screening protocol is listed on this slide deck. I think one of the major challenge is the limit eligibility. As you can tell, the age group is only between 55 and 74. That means the younger adults who are younger than 55 years old, or the older adults over 74 years old, they are not eligible for lung cancer screening, even in the provinces with a lung cancer screening system in place. And there's also a underdiagnosis because the non-smoker even there are the non-smoker, there are 15 to 25% of the cases actually occur in non-smoker. So that's why due to those population, this population is ineligible for the lung cancer screening. So that's why these potential patients are overlooked. And accessibility, as you can, if you recall from the last slide, so there's a geographic and the social economic disparity between the provinces in Canada. So that limits the accessibility to especially the low-dose CT-based lung cancer screening system. And there's sometimes it come to like the point of overdiagnosis. Very often, the identification from the LDC, the low-dose CT, which actually only identify like the benign nodules, which is really not relevant to lung cancer, and the follow-up is unnecessary. So that's why these kind of resources and from the LDCT, the low-dose CT, is not helping or facilitating the lung cancer screening in this case. And the cost, okay, the cost structure is quite significant given the infrastructure which is needed for the low-dose CT and the radiologist, right, which need to be placed. So that's why it's resource intensive from the current model for the lung cancer screening we have. And sorry, I think I missed slide. If we can go back to the previous slide, it would be great. Slide number 10. Yes, thank you very much. Yes, so for the lung cancer screening, very often recently, in the last 1 decade, there's an initiative on focus on the liquid biopsy, which is based on the reason liquid biopsy is much less invasive compared with any rare biopsy. And if we can go back to the previous slide, we can talk about the molecules of the, sorry, yes, perfect, this is the one. The molecules for the liquid biopsy, which could cover a quite wide spectrum. You can tell ranging from DNA to RNA to protein to cells, and even extracellular vesicles. So, which is always good to have these many potential analytes for the liquid biopsy, which you can tell corresponding to different staging of the lung cancer. There's always a correlation. You know, some of the biomarker could turn on positive, but some other ones are negative until the late stage. So that's why it's in our interest to look into, you know, what molecules, you know, including, for example, ctDNA, which is really the circular tumor DNA, and the microRNA, and protein biomarker, and the circulating tumor cells. Those combination of them, right? What is really happening in the lung cancer biology, which could provide the potential insight for our strategy of lung cancer screening early detection. So that's where our focus is. And from the central dogma of the biology, from DNA, RNA, protein, and metabolites, you can tell it's actually DNA, although the terminology we heard the most, but actually that contribute to the most unknown. We don't know a lot about how the entire genome is regulated, and the gene-to-gene interaction, and when the gene, which gene gonna be regulated, say turning on, turn up, or turn down. So that's why you see from DNA to RNA to protein to metabolites. So the amount of unknown actually decrease, and the number of diversities of molecule from DNA to metabolites actually become less and less. So that's why we are having this kind of potential hypothesis. What if we can leverage on the known knowledge from DNA to RNA to protein to metabolites to leverage something we know more instead of we know less, right? So that could potentially constitute a more robust, accurate, and specific panel for the lung cancer screening or detection. Okay, and then we're gonna go to the next slide, please. Yes, so this is a table which is quite overwhelming. I'm just gonna kind of walk you through. So this table is really listing all the pros and the cons for each type of the biomarker I list from the previous slide. I want to utilize, microRNA as example, which is really the one in the middle here. So microRNA is stable in the blood from the patient. It could create a very distinct or specific profile in the early stage of the lung cancer. But the downside for microRNA, the sequence has quite variability from patient to patient. So, also from lung cancer to say like a liver cancer or some other cancer type, so the specificity is not as high. And I want to take you to the other type of biomarker, which is really the last one on this table, which is a metabolomic biomarker, the metabolites. So those metabolites is nothing special like lactate, sugar, glucose in the blood. And those metabolites very often is actually cost effective and sensitive for the early stage detection. And the downside is a lack of the high throughput capability. So this is actually the reason why we're looking into the possibility if we could potentially combine the biomarkers, so that the combination of the entire panel could potentially offset the limitation of the individual category of the biomarkers. So that's where we get started. Okay, next slide, please. So this is the entire workflow for the conventional life science discovery. It's time consuming because I think the roadblock, I'm sorry, the previous one, the roadblock for the life science discovery is really, it takes quite some time to discover the biomarker individually through the publication. And then there's an accumulation of evidence from the literature. Yes, this is the one. And once we identify a good number of biomarker, so then the first step in this waterfall model, which is also the status quo we're dealing with in here, take sometimes decade, sometimes more than a decade to really identify what the biomarker panel is, and take quite a while to validate the biomarker based on its specificity and robustness and sensitivity, everything for the type of cancer of interest. And then that follow with the assay development, clinical validation, and then they'll come down to the implementation for the screening system, and followed by the long-term monitoring and optimization. So for this reason, you can tell this workflow usually is time consuming, and that's kind of the roadblock we're dealing with in here. However, recently, due to the machine learning, deep learning, or AKA artificial intelligence, so there's a great amount of computing power we could harness to speed up, to accelerate the discovery of biomarkers that will allow us to quickly, at least compare with the status quo on the left-hand side, we're able to roll into the assay development and the clinical validation more quickly. And the next slide, please. Perfect. And this is where our research started. So when I was an undergraduate student, I was fortunate enough to start the lung cancer research at that time. I was a student in China, and there were a lot of non-small cell lung cancer patients at a time. And this is actually the motivation why I became a scientist in the first place, because there's no really a solution from the clinical side. Because when patients come to the hospital, they are either mid or late stage. Very often it's the late stage of the lung cancer. And there's a very limited solution from the clinical side, which can make a difference. So that's why I was very passionate. I'm still very passionate to start the lung cancer research. And the goal at that time, you can tell from the research that was done between 2001 and 2004. So fortunately, with the collaboration back then in Shanghai, I accumulated a great number of lung cancer patient sample, biopsy sample after surgery. And we identified a very interesting potential biomarker, which turned on positive before lung cancer become metastatic. And during the COVID, and this research, biomarker research, actually also enable my research lab to identify the potential biomarker to highlight the sensitivity or susceptibility of the lung cancer patients to COVID infection and the outcome prognosis from there. So it's a trajectory for my own research and my scientific career ever since the beginning for lung cancer. And next slide, please. And so when I was a graduate student in McMaster University, and that was 2010, 2012, I was fortunate also to initiate a project that is based on machine learning, deep learning, to identify biomarkers from the patient samples. And of course, that at that time was no such robust tool for AI, but the deep learning, machine learning system was already initiated over 10 years ago in my research lab. So recently, this is actually my postdoc, Dr. Yiting Cai. So he utilized a very novel deep learning model where he introduced this algorithm which enable to differentiate or classify a different type of biomarkers for one disease. So basically, his deep learning model is able to narrow down a large or long list of different type of biomarkers to a very specific biomarker set, which is showing to be specific and for the disease of target. And the classification efficiency and the separation efficiency is much more optimal compared with the existing machine learning, deep learning model in the market. And we also introduced this algorithm for COVID disease diagnosis, for the stratification of the risk and the patient subgroups. And also we are able to introduce to a different disease model as a case study. Next slide, please. So we didn't stop in there. So the question is, what if we are able to narrow down the biomarker? How can we achieve the combinational detection for different biomarkers? So this is what the collaboration my research lab have done ever since like 10 years ago. So we were collaborating with a great outstanding engineering researchers in McMaster and globally as well. So we were able to fabricate different type of device using the bioprinting and the nano material fabrication. So this is the device we printed in order to enhance the sensitivity of a biomarker from the patient sample. And then recently we're utilizing the electrochemical sensor to really further enhance the potential detection for the metabolites. And so by comparing all the potentials of the existing sensor we have developed in the last 10 years, and we came down, so we integrate the sensing module into a lateral flow assay, which is what we call the multiplex LFA. So this LFA, it looks like the rapid testing test strip people were using during the COVID. But we are introducing our sensing technology into this one little device. The reason being, so for a few reasons. First of all, it's much more cost effective. Second, there's a very good social acceptance for this testing device. People are getting used to it during the pandemic, and they know how to do this. So we follow the entire routine and the process. So this avoid any kind of a learning curve from the user, which are the patients. And the next slide, please. Okay, so that's why we pick this. And yes, so this is the prototype for our multiplex lateral flow device. As you can see, a little bit different from the test strip you were using for the rapid testing of COVID. This one does not have the line. Instead, has array with all the different dots. In each dot, there was a printed precisely with a different probe corresponding to ctDNA, microRNA, metabolites, protein. And this information as a positivity, the positive dots can be easily taken a picture so to share with the clinician for data analysis. So that's why this device is suitable for the in-home testing. And it's very cost effective. The total price for per device is about $10 Canadian. So it's much more affordable. Next slide, please. Yes, so this just gonna be I'm gonna just quickly wrap up. So this basically the workflow of our device development. So start with the stage 1. So we are using AI machine learning to identify the biomarker. And the stage 2, we are utilize ChemSpeed, which the system we have in our lab, to automate the fabrication for this printing. And the third stage, we're gonna just to show you how quickly the testing results can become available. Basically, it's within the 3 minutes time mark. So it's quite quick, rapid, and suitable for in-home testing. Next slide, please. So this the advantages of the lateral flow, and I'm just gonna go to the next slide in this case. Yes, so this is the positive impact. So what we are showing in this product, and I'm very honored to be recognized by this award. And my team and I were very motivated to continue this research in developing this module, which going to contribute to the pre-screening. So this just want to let everybody know where this screening is not going to replace the low-dose CT screening, but this actually going to be a pre-screening system, allow us to apply this device to the population who are not eligible for the current screening system, so that we can increase the early stage rate detection, and we could include more population, non-smokers, younger adults, older adults, and reduce the amount of reliance on low-dose CT, the cost effectiveness for the screening and the patient outcome from there. Thank you very much, everybody.
Thank you, Fei. Congratulations again. And you know, when we have Lung Cancer Canada events with patients, and we talk about our priorities for trying to improve outcomes from lung cancer, and we talk about screening, and then you know, almost the most common question that I've been asked is from people who've not smoked, and they say, well, what about me? I wouldn't have been eligible for screening. And so it's really exciting to learn about all of the research that's going on in your work, to try and, you know, as you say, have the capacity to expand screening to populations that otherwise are not currently eligible. And we've seen some work in Taiwan that they've done very well in being able to expand screening beyond the traditional age and tobacco exposure criteria. And so your work hopefully will bring that, well, internationally, but also to Canada. So congratulations.
Thank you so much, Paul. Really appreciate it.
We are going to move to our second award winner, who, friend of Lung Cancer Canada, Professor Natasha Leighl. I should say though that there's no nepotism going on here. Natasha was the past president of Lung Cancer Canada before me, and before I passed on to Dr. Stephanie Snow. Natasha is a professor of medicine at the University of Toronto. She's a medical oncologist at Princess Margaret Cancer Centre, and internationally renowned researcher and thoracic oncologist. But she gets no special favors when applying for these grants, and goes through the same robust process that Dr. Zhu oversees. But comes out a winner, and we're excited, and congratulations, Natasha, on your award. And we're going to go kind of from early stage that we've heard from Faye to some novel technologies in advanced stage lung cancer. So it's kind of got a nice balance to it, these two awards. So Natasha, congratulations. I'll pass it over to you.
First, thank you so much. I'm thrilled. I was actually thinking, as I put together my slides, that I should be thinking about these things like nepotism. It hadn't actually occurred to me because, of course, as Paul and the team know, we apply every time to every competition, and we're so thrilled that we've won this year. So I'm really delighted. I'm going to ask Michelle if you can advance to my first slide, please. Thank you so much. So our project is at the other end. So once we know you have lung cancer, how do we make things better for patients? So, it's a tough journey. I think many people attending the webinar know this. First of all, somebody has to think that you might have lung cancer, or you have to figure it out and go to your specialist. You need scans, you need a needle biopsy of the lung or another site. We need to look at that under the microscope, make the cancer diagnosis. And now, thankfully, we also we test the tissue for certain genetic abnormalities and other abnormalities called biomarker testing to help pick the ideal treatment. And, it's great now in lung cancer. We have at least 9 different kinds of targeted therapy with tablets. And we also have a number of targeted intravenous therapies and also immunotherapy. But that biomarker testing is really essential to getting patients to treatment. Michelle, can I get you to advance for me? Thank you so much. So the problem is that, about 40% of people, this process just doesn't work, or it works very slowly. Some people have to go back for a second biopsy because the first biopsy just didn't give enough tissue. And so this takes time, it's inconvenient. And so we've learned that using a blood test, we can actually do this genetic testing or most of the biomarker testing through a blood test. And this is from, just broken down bits of cancer cells, and we can isolate the DNA from the cancer in the bloodstream. So, we've learned that using these, we call them liquid biopsies, more patients can get the information we need to make the best possible treatment choice. The numbers are 95% with liquid biopsies versus 30% without. It's faster, 7 days compared to 3 weeks. It avoids repeat biopsies, understandably a win-win for patients and everyone else. It also saves money and time. And also it gets patients to the best possible treatment faster. We've shown that it cuts the time to treatment in half. And blood tests can be done almost anywhere and shipped to a lab that can do the right kind of processing. Next slide, please. So how do we get this for all of our patients in the clinic? And this was the key challenge we sought to assess with our Discover program. Next slide, please. So in Discover, we wanted to look at 2 groups of people. The first are people where, they've had the biopsy, they've had the tissue testing, but it just doesn't give us the information we need. It's too small, it's taking too long, whatever reason. So we called this group of people Group 1, and these people have incomplete biomarker testing. The other group are people where they've been having treatment, in particular targeted or precision medicine, and the cancer is now changed, and we need to find the new genetic code for what this cancer will respond to. Normally, we would do another repeat biopsy through the chest or liver or wherever else the cancer might be. But again, can we use just the blood test to circumvent this? And so we have 100 patients in each group. They undergo the blood testing. We get it to our lab in the building, the Advanced Molecular Diagnostics Lab. And this undergoes a new type of testing. This is really, we look at 500 genes. This is really kind of state of the art. Not kind of, it definitely is. And so we're really thrilled to take advantage of this. And through this testing, what we've done is in the lab, we've been able to say, can we find the targets we need? Is this a test that's really reliable and helpful? And can we roll it out in the clinical lab where patients get their daily samples run? And so that's really been part of this process. We get a report, we go through it. If an oncologist has sent the patient to us, we also call that oncologist. We go through it together and with the patient, of course, to figure out if there's a new treatment or a trial. Next slide, please. So, so far, we've had some great success. We've actually been able to close cohort 1. We, at our center, we've now been able to validate, so make sure that the test is reliable and helpful, and move it over from the research lab to the clinical lab. So now patients at the Princess Margaret, when they come, if they meet the criteria for cohort 1, they can have the blood test in-house. They just go to the lab and we draw it along with everything else. Also, it's been recommended that from the quality team at the Ministry of Health that the ministry fund these liquid biopsies in Ontario for these patients where, they just don't have all the biomarker information from their tumor sample. And so we're looking forward to that being funded. And then, of course, we are going to be presenting these data tomorrow as a poster by one of our fellows at the International Society for Liquid Biopsy. And he promises me that the paper is in progress. Next slide, please. So where to from here? We're so thrilled to have access to this test at the Princess Margaret, but obviously that is nowhere near enough. We want every Canadian patient that needs this technology to have access. So we need funding, we need to get it to all of the provinces, and we're hoping to use our write-up from the Discover study that you folks funded to help us do that. Also, we want to keep looking at our second cohort. Can these people where the targeted treatment has stopped working on the cancer, can we use blood tests instead of invasive tumor biopsies to help direct the next set of treatments? So we're finishing up that cohort. And really with this, we want all of our patients to get the right treatment at a much earlier time. Also, this technology has the ability to help with much more. Can we do it before people have a biopsy and a diagnosis of lung cancer? Can we get rid of tissue biopsies altogether? Can it replace CT scans? And tell us, do we need to be worried about their cancer or not? Does somebody need a CT scan or not? So we do really want to support all of you. Our ambition is to enable access to this new technology for all of our patients funded through the healthcare system. And we're so grateful to all of you at Lung Cancer Canada and the Ambition Alliance. Without you, we couldn't have gotten this far and we can't get to where we're going. So thank you for all of our support. We are well on our way and hope to be there soon.
Thank you, Dr. Leighl and Dr. Geng, for both of you. Congratulations on your awards. We're going to have a little time now of Q&A. So if people have questions, you can drop them into the Q&A box, which is down there, and I'll moderate it. There's a couple actually for Faye. First question: what is tested in CEA blood testing? In what category of biomarkers is it? CEA is the blood test itself, isn't it? I think.
Yes. So I mean, sorry. Do you want me to answer that, Paul?
Sure. I think,
sure.
yeah.
So CEA is, it's an interesting marker. It is commonly found on the surface cells of cancer, but it can also be found in normal tissue. And in particular in colon cancer, it has been used to identify, kind of like our liquid biopsy that we're doing, whether the cancer is increasing in size or decreasing. But I think the challenge with CEA is it doesn't provide that genetic information, that allows us to pick a treatment. Also, we actually don't even currently recommend CEA for colon cancer. For lung cancer use, because it's really just not specific enough. Whereas with these tests, we get specific genetic information about the cancer that helps us help patients pick treatment.
Thank you. And Faye, a question for you. How reliable is your process in terms of sensitivity, specificity, and reproducibility? Which I guess speaks to how good is this going to be to take it across the country?
Yes, so that's exactly what we're about to initiate for the clinical validation. So the sensitivity, reproducibility, and specificity gonna be exactly the scope we are going to analyze during the pilot study. So this probably the pilot study gonna involve 15 to 20 patients to begin with. And then we're gonna recruit more patients, in a later study, to include the participants from across Canada.
Okay.
Mm-hmm.
All right.
And I just want to make a comment. Natasha, thank you so much for the information. I think that's exactly how we feel about the protein biomarker need to be combined with the genetic biomarker as well, because the specificity from the CEA, this kind of biomarker is not very specific to lung cancer. So that's why if ctDNA and the protein biomarker can be combined as a panel, that would be much more helpful.
There are questions flowing in, liquid biopsies. So, Natasha, before you answer, I'm going to take the chair's prerogative to speak my mind. But here's two questions. Valerie Spender says, are you using liquid biopsies to follow treatment progress currently? And then another question is cost an issue about liquid biopsies in screening? And then Raymond Laflamme, friend of Lung Cancer Canada, asks, again, going back to CEA, and I guess, Faye, you've kind of mentioned this a bit about combining these biomarkers, but would a CEA be a trigger for a liquid biopsy? So I was just on the phone this morning with a patient of mine who I'm looking to get a liquid biopsy on. She's already got lung cancer and not anything easy to biopsy, and she's going to pay for that biopsy, and that's thousands of dollars. So at least in Ottawa, and we're one of the bigger academic centers, we do not have access to liquid biopsies to routinely follow patients. Natasha, are we going to get to that point, do you think? And how soon? And maybe a question about cost.
Great, thanks. And I'll try and keep it short. Thanks so much, Paul, and thanks for these great questions. So there are three issues. Cost is the last piece, but the first question is, is the technology good enough? So if somebody has advanced lung cancer, to find certain genetic markers, yes, the technology is great. We know that if we find something in plasma, we don't need to go back and do a biopsy, that we can pick treatment and it should work just as if we'd done it with tissue. So technology in somebody with advanced disease to pick treatment, excellent, ready to go, guideline recommended. To monitor patients, to say treatment's working or not working, we're still in the research phase. Some great work going on. Dr. Paul Wheatley-Price is part of this as well with the Canadian Cancer Trials Group to say, is immunotherapy working? Are target therapies working? Do we need to add chemo or not, or switch? And, these are a little more challenging because we do have to figure out, is a test good enough to say, yes, you don't have to worry? Sometimes tests get missed or results get missed, so, false negatives, for example, or sometimes false positives. We find it, but it doesn't really mean anything to the patient. And so these are really important. We don't have a handle on that yet. The next question is, well, what about clinical utility? So what does that mean? So that means, if we use it, does it help? Does it really help people, or is it just another test? So if I do the blood test, can I tell you, yeah, you totally don't need a CT scan, come back, see me in 3 months, you're going to be just fine. So to prove that, we have to do the research, and that's part of what you guys help us do. Cost, yes, cost is always a challenge. Where this is guideline recommended, in the advanced case where we were doing cohort 1, the money and funding. For example, Paul, your patient, she should have access to liquid biopsy rather than having to do a repeat tumor biopsy or being told, look, I'm sorry, we can never get the genetic information for your cancer. Other things, monitoring, screening, we're not there yet. But thanks to the earlier speaker and a lot of work that many of us are doing around the world, we're hoping very soon to get there within the next year or two.
Natasha, just a quick follow-up question. There's maybe one of the same questions asked, is liquid biopsy now considered to be accurate and affordable? And I know you've just kind of answered that question, but just to expand on it, how many times would you say there is a complete discrepancy between a result you'll get from a liquid biopsy compared to a conventional needle tissue biopsy, going either way, like the tissue biopsy is right and the liquid biopsy is wrong, or the other way around?
Thanks.
And are we ever going to get to a point of, like, never complete concordance, but an acceptable level of concordance?
So I think especially in the setting for someone with advanced lung cancer and some of the commercially available liquid biopsies, I think we're already there. This is an advanced disease. So I think the concordance is pretty near 100%. The big challenge is that sometimes a person's cancer isn't breaking down sufficiently, or they just have a little bit of cancer in the body, and so we can't actually find it in the blood. So that's about 20% of people with advanced disease where, even if I do the blood test, I'm not going to find any of the DNA related to cancer. Sometimes you find DNA that's a little bit abnormal, just even if you don't have cancer. So, we're getting much better at figuring out, like, what does that look like? It's something called clonal hematopoiesis. So I would say that right now concordance is pretty great. We are looking at, very rarely sometimes I might find something in blood and something different in tissue. That almost never happens. I would have to say that's less than like 0.1% based on work that we've done and work we've done on Discover. It's more that, we can't find enough in the blood. Sometimes for certain things like, fusions or genetic increases in copy numbers, something like MET amplification, sometimes we might miss that in the liquid biopsy. So the rules are in the clinic, if you don't find it in a liquid biopsy, go look for it in tissue, because we never want to miss a marker in a patient.
Right. Okay, and I guess that's a good segue on to, I think, what will make the final question, and then I'm going to pass things over to Zhaolin. So this last question that's come in from Inam Al-Strahin is, can liquid biopsy be effective for detecting early stage lung cancer, and what are the limitations? And Natasha, you kind of already touched on that in advanced stage, that there are some people that just don't shed enough cells into the bloodstream, and if there's very little amount of cancer, then that could be a problem. And so maybe I'll ask both of you this question then: is early stage lung cancer, is it just too early to have released enough material into the bloodstream to be sensitive? So Natasha, maybe you could follow on from there, and then Faye, maybe I could ask you what your thoughts are on liquid biopsies as a pre-screening strategy, if you like.
Sure. Paul, I think this is really just a part of the scheme of cancer tissue trying to achieve its agenda. So we know we're still in the process of understanding the correlation of the entire big picture, why they are doing this, and what's the released DNA or microRNA is facilitating their agenda, either metastases or angiogenesis. So that's why, yes, early stage, even very early stage, that could be a sign which can be detectable. That's actually the motivation for this, like a machine learning, deep learning powered biomarker discovery, because there's so much more we could identify, beyond our current knowledge of lung cancer biology.
Thanks. And, I think just to add to that, the currently available tests, they're really good if you've got, sorry to say this, lots of cancer. If you've only got a little bit of cancer, you actually need different tests. So these tests are kind of fit for purpose. So in advanced lung cancer, that's sort of a test that picks up sort of more genetic material in the blood. But then for these, like, if you're looking for it, or if it's screening and you're trying to detect something and the cancer is small, you need a much more sensitive test. So what's the problem with that? Well, if you're really diving deep and looking for 0.0001% of the genetic material in the blood, because there's also like normal stuff in the blood too, right? We call that background noise. There are two things you can do. You can you can follow more alterations that are from the cancer. So these require, a little bit of a person's cancer. Then we make them their own personalized liquid biopsy panel, and we look for just those cancer mutations in the blood. And if I'm looking for one, it's a little bit harder to find than if I'm looking for 50. So then, the commercially, some of the tests are marketed, these precision panels for, minimal residual disease. Right now in lung cancer, they're not proven to help. because now, you know, we're learning you probably need like 2,000 or even 10,000 mutations that you follow. And also a way, you know, using some of the science that Faye was talking about to screen out this background noise. So cancer really lights up and normal stuff kind of sinks to the background. So that's where we're headed next. Things like adenocarcinoma, much harder to find than less common cancers in Canada, like squamous carcinoma. But, you know, we're all working very hard on this and we will get there.
And Natasha, I just want to make a quick comment on this. This is actually quite interesting because our interest actually also roll into the detection of our body response. Because if we put pressure on our detection, very often, you know, you just detect one molecule, but guess what? Our body actually senses the presence of cancer. So from the entire metabolites, we can tell the difference in a different way, even like the breath.
Fantastic.
I'm going to thank you both for this terrific session. I want to give Zhaolin a few minutes to finish up. You know, at Lung Cancer Canada, we have an advocacy strategy, and for many years we've been calling on you know, lung cancer screening as being our number one advocacy ask, and then access to treatments. But supporting cutting edge research is now becoming a pillar of our advocacy work at Lung Cancer Canada, and it's award winners like Dr. Leighl, Dr. Geng, who are really making it an exciting time for us at Lung Cancer Canada to be partnering with Lung Ambition Alliance and other groups in our research awards, but specifically Lung Ambition for the purposes of today. I am going to pass over to Dr. Zhu. We've known each other for, gosh, many, many years. He's a pathologist, runs the thoracic program at Dalhousie and QE2 in Halifax, and he has been the chair of our Lung Cancer Canada Research Advisory Committee for the last number of years. So, Zhaolin, let me pass it over to you.
Thank you, Paul, for your introduction and your hosting and moderating the webinar. Thank you all for being here today and for your active participation in this important discussion. As we reflect on the groundbreaking research shared by our esteemed speakers, it is clear that initiatives like the Lung Ambition Awards play a crucial role in propelling advancements in lung cancer care. The innovative work being done by researchers like Dr. Fei Geng, who is developing a new blood-based test for cost-effective lung cancer screening, and Dr. Natasha Leighl, who is integrating liquid biopsies, so liquid biopsies into the care of patients with advanced lung cancer, is not only inspiring, but also pivotal in addressing the pressing challenges we're facing in this field. These projects are paving the way for early detection, personalized treatments, and ultimately better patient outcomes. The Lung Ambition Awards aim to close critical gaps in lung cancer research and bring us closer to improving outcomes for patients across the country. By supporting such initiatives, we are investing in the future of lung cancer care, ensuring that advancements in prevention, screening, diagnosis, treatment continue to be at the forefront of our efforts. We must remain committed to understanding and addressing lung cancer, which remains the most common and deadly cancer in the world. I would like to take the moment to recognize the invaluable contributions of our partners, the Lung Ambition Alliance and AstraZeneca Canada. Their commitment to advancing lung cancer research is instrumental in driving innovation and ensuring that we have the resources necessary to make a significant impact in this area. It is through these collaborative efforts that we can elevate lung cancer research to a new heights and push for more equitable healthcare landscape. As we move forward, I encourage each of you to stay engaged with Lung Cancer Canada's research initiatives, whether through attending further forums, sharing findings within your networks, or advocating for increased funding and awareness. Your involvement is vital in our collective efforts to improve lung cancer care. Together, we can amplify the voices of researchers and patients alike, ensuring that the advancements in lung cancer care reach those who need them most. Thank you once again for your time, your contributions, and your dedication to this cause. I look forward to seeing how we can all work together to bring about meaningful progress in lung cancer research and care. Thank you.
Thank you, Zhaolin. Thank you, everyone, for joining us, and for the Lung Cancer Canada team for putting this together today.